This is the Noble compression test. I'm going to flex the hip to 90 and the knee is going to also be at 90 degrees of flexion. I'm going to find the IT band by putting my knees on the lateral epicondyle of the knee. I'm going to start to extend the knee slowly until it gets to about 30 degrees to about knee extension. I'm going to have either a pain response. The athlete will say that that's painful when I get to that range, and when I start to flex it, it doesn't hurt as much, and that will be a positive test for IT band friction syndrome. This next test is called the McConnell's test. I'm going to passively put the knee at 120 degrees of flexion. I'm going to ask the patient to give me some resistance and kick against me. Good. I then move her to 90 degrees, kick against me, move her to 60, good, 30, and then 0. If the patient complained of pain at around 60 degrees, I'm going to put her back in that position. And then from here, what I'll do is I'm going to put a lateral force. I'm going to put force on the lateral aspect of the patella, pushing it more medially. And I'm going to have her again push against me. If there's a decrease in pain, that's going to be a positive test for patellar instability. This is going to be the patellar grind test, and this is going to be for patients with possible chondromalacia, or they may have a articular issue between the condyles of the femur and the patella itself. So with the patient supine, I'm going to go ahead and apply compression directly over the patella. I'll ask the patient to contract their quads, and a positive test would be grinding felt underneath my hand, or if there was pain expressed from the patient. This is the patellar ballottement test. With my left hand, I'm going to go ahead and compress on the superior aspect of the patella. Same thing with my right hand, but on the inferior side. And from here, I'm going to assess if there is any excessive edema by the distance between my thumb and my index finger. If they can't touch, that is a sign of excessive edema. Another way of doing this is from this position, using my index finger to push down on the patella. And if I can't feel the back of the patella on the femur, that also is a positive test for edema. This next test is going to be the stroke test. So I'm going to apply some pressure superiorly on the medial aspect of the knee, and you can do this a couple of times. And then from there, I'm going to follow it with a down pressure on the outside of the knee. And what I'm looking for is a fusion, and this can be done and graded in different rates. So if I see a small wave during the downstroke, that's going to be a trace 0. If I see a larger bulge on the medial side during that downstroke, that's going to be a 1+. If I see a fusion returning after the upstroke and no need to see the effusion with the downstroke, that's going to be a 2+. And then if I see any effusion so thick that I don't really even need to do an upstroke, that's going to be a 3+. And like I said, this is just testing for joint effusion. This test is called the EGGI, and what I'm going to have the patient do is externally rotate your feet so you're in a ballerina position and squat down to a nice comfortable position as far down as you can go. A positive sign would be if she has pain or reproduction of that knee pain. Then from here, I can have her now go toes in, deep internal rotation, and I'm going to have her squat down as much as possible. And if there's pain or reproduction of symptoms in her knee with this, I would think that that's more so on the lateral aspect of the meniscus, as opposed to the beginning when she was externally rotated. That would be more so of the medial aspect of the meniscus. This test is going to be called the Apelles maneuver. So what I'm going to do is I will bring her knee into flexion around 90 degrees. I'm going to put a compression load towards the foot, and I'm going to go ahead and rotate. And what I'm doing is I'm assessing for any clicking, any grinding, or any pain from the patient. I can also do this, and that would be testing for the meniscus. If I want to do the Apelles distraction, I put one leg underneath, and I'm going to now pull up and I can also add some internal and external rotation. And what this one is assessing for is actually the ligaments, and positive test for this one would be pain or any laxity. This test is going to be called the McMurray's. I'm going to go ahead and passively move the leg into hip flexion and knee flexion. From here, I'm going to go ahead and, if I were testing the lateral meniscus, I'm going to internally rotate the tibia. I can apply a valgus force to the knee, and I'm going to go ahead and bring them out. And I'll go ahead and continue this motion. Make sure that there's internal rotation. I'm actually going to lower the table just a little bit. Good. So, internal rotation, and you can bring the leg out. And a positive test for this one would be if I hear any clicking and popping. Remember, that's the lateral meniscus. If I want the medial meniscus, I'll externally rotate the tibia. I can apply a valgus collapse, a valgus force to the knee. And again, I'm checking for any clicking, popping, or any increase in that pain. And that would be for a meniscal tear. This is going to be the Thessaly test, and it's testing for meniscal tears on the medial aspect or the lateral aspect. So we can have the patient with her knee in 5 degrees of flexion and in 20 degrees of flexion towards the end. I'm going to go ahead and just show it in 20 degrees of flexion for time's sake. So with the patient extending on one leg, you ask them to bend the knee. Keep your pelvis and your hips aligned with mine the whole time. Okay. And you're going to slowly turn to one direction to the end, and then you're going to go ahead and turn to the opposite direction all the way to that end. And a positive would be clicking, popping, or an increase in symptoms on either the medial or the lateral side. This is the posterior lateral instability test, and it is testing for the LCL, arcuate complex, popliteal complex, and the third lateral capsule if positive for grinding or pain. So I'm going to have the patient up into hip flexion and knee flexion. I'm going to add a slight valgus force while I'm going to then extend the knee at the same time. I could do this a few times, and as I said before, pain would be popping, clicking, or pain on that complex. This next test is going to be called the pivot test, and the pivot shift test, and this is going to also be for the anterior lateral rotary instability. It's testing for the ACL, posterior lateral capsule, arcuate popliteal complex, LCL, PCL, and the IT band. So with this test, I'm going to be starting an extension. I'm going to have a valgus force, turn the tibia into internal rotation, and I'm going to now be flexing the knee instead of the opposite way, which was starting in flexion. And a positive test for this would be clicking, popping, or any increase in pain on that knee. Now I'm going to go ahead and do the Slocum's test. I'm going to go ahead and flex the knee and put it in a position like for the anterior drawer test. I'm going to internally rotate the tibia to about 30 degrees. You can sit on the foot if you need. And now I'm going to go ahead and apply an anterior force. Then I could do external rotation to about 15 degrees. And again, I'll go ahead and apply an anterior force to that as well. Positives would be clicking, popping, or an increase in pain. If I were turning it to the medial side for internal rotation, I'm going to be stressing the anterior lateral aspect. So the ACL, posterior lateral complex, arcuate complex, PCL, and the IT band. And if I turn the foot to the external rotation, I'm stressing the medial complex of the knee. This next group of tests that I'm going to be doing is going to be for the PCL, and the first one that I'm going to show is called the posterior sag sign. So I'm going to go ahead and flex the knee up to about 40 degrees. Make sure that actual knee joint is at the 90-degree angle. And from here, stabilizing both, I'm going to just be observing to see if there is any posterior sag of the tibia on the femur by looking at the tibial tubercle. Since she's cleared and there's no sag, that is a negative test. And going straight into now the Godfrey test, which again is just for the PCL. I'm going to now lift her hips and her knee to the 90 degrees. And from here, I'm again just visually observing to see if there's a sag of the tibia on the femur. Of course, she's completely fine. If there was any pain associated, that could be with a grade 1 or grade 2 as well, with not so much laxity. And then finally, the last one for just the PCL is going to be called the posterior, it's going to be called the posterior drawer test. Going back to that 45 degrees of hip flexion, 90 degrees of knee flexion, I'm going to go ahead and sit on the foot. And then from here, I will wrap my hands around the tibia, and similar to the ACL, I'm going to now instead push down straight, and a positive test would be posterior translation or pain of the tibia on the femur. This next group of tests that I'm going to put and explain is going to be for the ACL. The first test is going to be called the Lachman's test. So with the knee extended on the table, I'm going to put my left leg underneath the patient's popliteal fossa. I'm going to use my left hand as a stabilizing force for the knee. And I'm going to put my right hand and cradle it around the tibia. And from here, I'm just going to push an anterior force up from the knee. A positive sign would be anterior translation of the tibia on the femur. And this was, again, for a ACL, either full rupture or a sprain. Going into now anterior drawer, which is also for the ACL, I'm going to put her hip in 40 degrees of flexion, her knee in 90 degrees of flexion. I will then sit on the foot for that extra stability, put my hands around the tibia, and now I'm going to go ahead and pull towards me. Anterior translation means that would be a positive test for either a full rupture or a sprain to the ACL. This next group of tests is going to be for the medial collateral ligament or the lateral collateral ligament, starting with the Houston's group test. I'm going to have the patient's leg on the table. From here, I'm going to, correcting this video. Start off with a valgus force, so Houston's valgus, which is stressful to the MCL. I'm going to do it at 0 degrees first. So I'm going to put a valgus force with the leg on the table. I'm going to put that valgus force stressing the MCL at 0, slight bend, 30 degrees. Valgus force, again, this is for the MCL. Moving on to the Houston's varus test for the LCL. Again, the leg is on the table, starting at 0. I will turn my body. And I'm going to put my hands on now the inner part of the leg, creating a varus force with her leg at 0 degrees. Then again, slightly more off for that 30 degrees of flexion. Again, varus force for the LCL. And this is Houston's. This next group of tests will be testing the MCL and the LCL. This is just going to be the varus and valgus test standard. Starting with the varus test, stressing the LCL, I'm going to elevate the leg with the leg at 0 degrees, apply that varus force. Then I'll go ahead and make it with 30 degrees of flexion. What that differentiates is with the greater amount of flexion in the knee, isolates out that ligament a little bit more. So again, if I were to do it at a valgus force, valgus force, picking up the leg at 0 degrees, stressing the MCL, in addition to other tissues. If I wanted to do a little bit more of isolation for that MCL, slight flexion with 30 degrees, apply that valgus force. Positive test would be pain, increased laxity, and instability.